Bismillahirrahmanirrahim. ARDS, pathophysiology and diagnosis. The definition and epidemiology of ARDS. Acute respiratory distress syndrome (ARDS) is not a single entity, but res- represent the severe end of a spectrum of acute lung injury due to many different insults. Manifests as acute and persistent lung inflammation with increased vascular permeability, most commonly seen on the ITU, where about 10 to 20% of such patients will have ARDS, depending on the definition. The 2012 Berlin definition of ARDS requires the following: respiratory symptoms within 1 week of known clinical insult, bilateral opacities consistent with pulmonary edema on chest radiograph or computed tomography. Respiratory failure must not be fully explained by cardiac failure or fluid overload, and the echocardiogram may be required to exclude hydrostatic pulmonary edema. Oxygenation impairment, defined by PaO2 over FiO2 ratio at least below or equal to 300 millimeter mercury, which is equal to 40 kPa, despite positive end expiratory pressure equal or more than 5 centimeter water. Mild ARDS, PaO2 over FiO2 more than 200 millimeter mercury, and moderate ARDS, PaO2 over FiO2 more than 100 millimeter mercury. Severe ARDS, PaO2 over FiO2 below or equal to 100 millimeter mercury, which is equal to 13 kPa. Other ARDS grading scores exist, such as Mary Lung Injury Score based on plain chest X-ray findings, oxygenation, PEEP level, and respiratory system compliance. The pathophysiology: inflammatory damage to the alveoli either by locally produced pro-inflammatory mediators or remotely produced and arriving via pulmonary artery. These mediators recruit neutrophils which release proteases and reactive oxygen species causing capillary and alveolar damage, and changes in pulmonary capillary permeability allow fluid and protein leakage into the alveolar spaces with pulmonary infiltrate. The alveolar surfactant is diluted with loss of its stabilizing effect, resulting in diffuse alveolar collapse and stiff lungs. This leads to gross impairment of ventilation perfusion, matching with shunting, causing arterial hypoxia and a very large AE gradient, and there are usually enough remaining functioning alveoli such that hyperventilation maintaining CO2 clearance, thus hypercapnia is infrequently a problem. Pulmonary hypertension will develop secondary to hypoxia, but this may be helpful aids VQ matching rather than deleterious. Reduced compliance, which means stiff lungs due to loss of functioning alveoli, that's to say alveolar collapse filled with fluid and protein, and hyperinflation of the remaining alveoli to other limits of distension. Common causes. There are many causes of pro-inflammatory mediator release sufficient to cause ARDS, and there may be more than one present. Common causes in order of prevalence include the following: sepsis over pneumonia, It's to say risk increased with alcoholism and cigarette smoking, gastric distension or gastric aspiration, even if even if on proton pump inhibitor PPI, indicating that a low pH is not the only damaging component, trauma or burns via sepsis, lung trauma, smoke inhalation, fat emboli, and possibly direct effects of the large amounts of necrotic tissue. Less common causes include the following: acute pancreatitis, transfusion related acute lung injury, transplanted lung, and post bone marrow transplant as bone marrow recovers. Drug overdose include tricyclic antidepressants, opiates, cocaine, aspirin, near drowning, and the following upper airway obstruction, and here the mechanism is unclear. The course of ARDS is fairly characteristic. Phase 1 is the early period of diffuse alveolar damage and hypoxemia with pulmonary infiltration, and phase 2, which is fibroproliferative phase, develops after a week or so as the pulmonary infiltrates resolves, and the histology seems to be associated with an increase in number in type 2 pneumocytes, surfactant producers, and the myofibroblasts, and the early collagen formations. The phase 3, which is called fibrotic phase, occurs in some. This is a fibrotic stage that leaves the lung with cystis, deranged microarchitectures, and much fibrosis on histology. Clinical features: ARDS should be considered in any patient with a predisposing risk factors with a predisposing risk factor who develops severe hypoxemia and widespread diffuse pulmonary infiltrate. Approximately 1 to 2 days following the clinical presentation of the precipitating cause, sepsis or aspiration, and so on, there is rapidly worsening dyspnea, plus or minus a dry cough, and hypoxemia, requiring rapidly oscillating amounts of supplemental oxygen up to 100% via a non-breathing system. Coarse crackles in the chest, intubation and ventilations are nearly always required, although initiating high flow nasal cannula oxygenation or continuous positive airway pressure CPAP via a face mask at a 5 to 10 centimeter H2O with 100% O2 can improve oxygenation temporarily. Diagnosis of ARDS: there are no specific tests that allow confident diagnosis, and exclusion of other more specifically treatable diagnosis is required. The cause for ARDS need to be established and prevented from continuing or recurring. If possible, the chest X-ray or CT shows diffuse alveolar infiltrates and air bronchograms similar in appearance to cardiogenic pulmonary edema or diffuse pulmonary hemorrhage. Changes are worse in dependent areas. The differential diagnosis of ARDS include left ventricular failure, may be excluded on clinical grounds, may be excluded on clinical grounds, echocardiogram, or less commonly checking pulmonary capillary wedge pressure, which will be below 18 millimeter mercury. Diffuse alveolar hemorrhage, Goodpasture, Wagner, and systemic lupus erythematosus. Clues will include a drop in hemoglobin, blood in the airway, and the pulmonary secretions, and the other clinical features of one of these disorders. Interstitial lung disease, acute interstitial pneumonia, or fulminant pneumonia, also present in the differential diagnosis. Idiopathic acute eosinophilic pneumonia and cancer and the lymphangitis carcinomatosis also are in the differential diagnosis. Some centers advocate lung biopsy to exclude alternatives, although most reserve biopsy for cases when the differential diagnosis include conditions for which management would be changed, as for example fungal infection, vasculitis, cryptogenic pulmonary pneumonia. Thank you. That's all, and thank you.